Acute thrombosis affects the fistula within the 30 days after it's been created. And timing is very important for two reasons. One, the longer you leave it, the likelihood of success is less, and it can create endothelial damage, and organization is a bit more, and as a result, removal may be difficult. Hypotension is one of the commonest factors identified in the early thrombosis, and to some extent, technical factors are also responsible if it happens immediately after surgery within the first few days. And early removal is very important because you can avoid a central line placement. The recommendation in this scenario is to act on it as quickly as possible with investigations as necessary. And generally, surgery is recommended in early acute thrombosis, and you take the patient back to theater, look for the issues in the anastomosis itself, and see if you have missed out anything in the first time round, and if possible, combine that with on-table fistulogram or DSA, and identify any lesions you have missed out and correct it. Common factors, technical, hypotension, which is number one problem in every access case. You need to look out for that and make sure that you avoid that if you can. And previously unrecognized hypercoagulable state, if there is any, please look for it. And other than that, usual culprit is undetected lesion, either in the anastomosis or in the inflow, or just beyond in the outflow vein, usually. And what are options you have in acute? You would have both endovascular and surgical, or a combination of both. Quite a few endovascular options are available, which involves thrombolysis, mechanical methods, and you can combine that with surgical option and make it as a hybrid procedure where you could remove predominant clots and use your DSA techniques and thrombolysis and identify an underlying stenosis in usually the outflow tract just beyond into the draining vein. And if in the case of AV graft, usually beyond at the anastomosis or just beyond that into the venous, which is venous segment, which is draining. What's the recommendation here with the USVS? They say that access thrombosis should include perioperative diagnosis and looking out for any stenosis. That's number one recommendation. Endovascular techniques, you probably are already familiar with this. You'll have thrombolysis, a combination of pharmacological and mechanical thrombectomy techniques, and any of these combinations you might pick based on your expertise available in the institution. To begin with, there's an example here. This is an autogenous BVT which got thrombosed, and thrombolysis was set up, and 12 hours later we identified a lesion just beyond in the juxtaanastomotic area. It was angioplasty. That led to a good outcome. And this is in the case of AV graft, thrombolysis was started, and then after 12 hours, we were able to open up a thrombosed axillary artery to vein graft and restart dialysis without any need for a central line. And this is a combination where we combined, my surgical colleague opened up the graft and he removed most of the thrombus. He dealt with the inflow issue with angioplasty, and then subsequently in the outflow tract, he found these stenotic lesions. Apart from thrombectomy, he also stented it, angioplasted it just beyond into the draining axillary subclavian segment, which led to a good outcome. So this is a hybrid procedure where all methods were used in theater. So based on your experience, I think you would agree with me that in the case of autologous graft, you need to rush in and do as much quickly as possible to preserve the function, prevent inflammatory response and endothelial change. And in grafts, you have some time to play with. You can set up all the necessary logistics in place and then go and carry out retrieval of this graft. Older thrombi, more than 5 days. Surgically, it may be difficult, so you may need to have modified thrombectomy catheters, and you probably will need to use your interventional colleague to help you out in theater to clear it. Usually there is a lesion proximal distal to it, just to deal with that. Surgical thrombectomy and on-table angio would be my usual preferred method in complex cases like this, and as such, all my colleagues do this. Wherever you want to do a surgical thrombectomy, you need to think whether I could have asked my interventional colleague to sort this out instead of myself embarking on it. But there is no convincing evidence. But in autologous fistulas, there is no convincing evidence that one is better than the other. But whereas in AV grafts, endovascular approach is shown to be giving a better results than autologous fistula formation. So at 1 year, endovascular versus surgical approaches give similar results as far as graft thrombosis are concerned. Essentially, in these cases, you should act quickly, especially if you have autologous fistula, and you have a combination of treatments. Make sure you set up all the help possible to make sure you retrieve this. And there is always an identify underlying cause which you have missed out or which has developed. Don't forget, neointimal hyperplasia also takes place in fistulas, and usual places are on juxtaanastomotic areas and also in the draining vein just beyond the graft. Thank you.